Okay, next up is the motor system. So today we're going to talk about terms to describe motor output, but we're also going to talk about how our body moves. First, let's talk about a couple terms that are often used to describe impairments with neurological disorders. First, hypotonia, which is described as decreased muscle tone. Sometimes it's described as floppy or loose muscle, and flaccidity is extreme loss of muscle tone, where there is actually no muscle contraction. Hypotonia is often seen with shock after an acute injury, such as a CVA or spinal cord injury, or with lower motor neuron diseases. Sometimes it can also be developmental. For example, patients with Down syndrome often have hypotonia. Down syndrome is a chromosomal condition because there's an extra copy of chromosome 21. Common symptoms are hypotonia, flat facial expressions, intellectual disability, and developmental delays. Then we have hypertonia, which is the opposite, so this is increased muscle tone. Sometimes it is described as stiff or tight. We can see this with chronic injuries or upper motor neuron injuries. This often develops later after that acute spinal or brain shock resolves. It happens because motor neuron activity is not well modulated. Developmentally, this can also occur. Cerebral palsy is a disease process that can cause hypertonia. Cerebral palsy is due to damage or an abnormal development of the brain in infancy or early childhood, and it can lead to stiffness or the inability to move joints and limbs, which can put patients at risk of getting contractures and can have big impacts on ambulation and transfers. Sometimes you will see scissoring of gait or walking on tiptoes, and these are two characteristics of cerebral palsy due to this complication of spasticity. We want to differentiate between two types of hypertonia. So we have spasticity and rigidity. Both of these are increased muscle tone, but there is a distinct difference. Spasticity is speed or velocity dependent. You may not see an abnormal response if you stretch a muscle slowly, but you will see an increased response in that muscle tightness or tone when you increase the speed of how quickly you stretch a limb. For example, clonus, which is a quick stretch to the plantar flexors, can cause spasticity, and it can impact walking, especially when we're trying to increase walking speed. And then we have rigidity, which is increased muscle tone, but it's independent of speed. You will see this a lot in patients with Parkinson's. They have an overall kind of stiffness to a lot of their movement quality. So again, rigidity is that increased tone, not dependent on speed. And you often will see rigid posturings with brainstem strokes or significant TBIs. So these two pictures are two types of posturings when there is an injury to the brainstem. Decorticate posturing, the elbows are flexed and the wrists are also flexed. And then decerebrate, the elbows are actually extended, but the flexion of the wrists and fingers remain. We see decerebrate posturing a lot when patients are in a coma. Both of these posturing responses can be elicited with positioning, such as like moving a patient's head with bed mobility or noxious stimulus like a sternal rub. Typically, both of these posturings usually indicate a poor prognosis. A couple other terms we need to know about the motor system are involuntary muscle contractions. So we're going to talk about a few in the next couple of slides. First, fasciculations, which is a quick twitch of the motor unit. So it looks like a twitch or a ripple a lot of times when this is occurring on a patient's leg or arm. It's normal with vigorous activity, dehydration, and stress. Like, for example, if you've ever worked out really hard, let's just say you maxed out on your leg press for the day and your quads kind of fasciculate afterwards, it can just be a sign of fatigue. It's abnormal when it's associated with a motor neuron disease such as ALS or Huntington's. Myoclonus is the involuntary contraction of a muscle or muscle group. So this is that clonus, that plantar flexion clonus that I was talking about just a second ago. And this is abnormal post-injury. So when there's a quick stretch to the plantar flexors of the ankle, there are repeated plantar flexor contractions and it causes a beating of the foot. Typically, this does fatigue and terminate. Next up, we're going to talk about tremors. So tremors are a quick contraction of opposing muscle groups. For example, the supinators and pronators of your wrist. There are a few different types. So first is a resting tremor. This is seen with Parkinson's disease, and it doesn't require any movement, so it truly is at rest. Oftentimes you see this in hands. Then we have action tremors, which is when the limb is outstretched against gravity. We have postural, which is an outstretched arm, and the arm is actually against gravity that causes a tremor. Orthostatic tremor is seen with standing or a change in position. And an intention tremor indicates a cerebellar problem. So this is seen when we're performing a specific task, such as finger-to-nose testing. And lastly, we have an essential tremor, which is actually inherited. And this tremor kind of happens all of the time. It's mostly seen in the hands, but it can actually affect the head and the voice as well. So I want you to pause for a moment and think about some of these involuntary muscle contractions and how they can affect function. Some ways hypotonia can impact function is due to that decreased muscle activation. It can be challenging to maintain positions. If you're thinking about a baby that has Down syndrome, they may need extra support to maintain seated posture. If there's hypotonia, it might be difficult to maintain posture when you're standing or walking. Hypertonia can cause a decrease in range of motion. For example, flexor tone of the hand can make it difficult to grasp and release objects. Sometimes an increase in tone can be helpful after a nervous system injury. For example, if we have increased extensor tone of our quadriceps, which causes our knee to actually be kind of stiff and straight, it can actually help with transfers initially when a patient is rehabilitating after a CVA or a traumatic brain injury. Spasticity, we have to be kind of careful about moving or helping patients move too quickly. It's often seen when we're trying to increase the speed of walking or transfers. We can see the impact spasticity has. Tremors can affect a lot of things, specifically the ability to perform smooth, precise movements, such as like feeding yourself, applying makeup, buttoning shirts, and these are just a few examples of how increased or involuntary muscle actions can impact function. Next, let's talk about reflexes. So, a reflex is an automatic or involuntary response to a specific stimulus. Typically, reflexes are fast and they occur as a protective mechanism. For example, a withdrawal reflex when you touch something hot. However, injury to the nervous system can also impact reflexes. So we can have hyporeflexia, which is a less responsive reflex to a stimulus. This is usually indicative of a lower motor neuron injury. And then we can have hyperreflexia, and this is an increase in response to a stimulus, and this is often seen with an upper motor neuron injury. So a couple of signs that we use or reflexes that we can test to give us some information about the upper motor neurons or the central nervous system is the Babinski. So this is where you're taking a reflex hammer, or a pen and you're drawing a 7 on the bottom of the foot, if the toes flare out, this is an abnormal response. A normal response is when you draw the 7, the toes actually kind of flex or bend down towards the pen or the reflex hammer. This toe flare or a positive Babinski sign is normal in babies until about 7 months, but it's indicative of an upper motor neuron lesion if it's seen outside of that 7-month window. Hoffman's sign is another test that we can use that will tell us if we have to be concerned for upper motor neuron injuries. This is where you're going to hold the middle finger steady and you're going to flip the top of the middle finger downward. The test is positive if the index and the thumb flex as well. So if all 3 fingers, middle, index, and thumb flex, that's a positive sign indicating an upper motor neuron lesion. So to understand all of this about motor control, we also need to kind of understand some diagnostical tests that can be completed in regards to muscles and nerves. So a nerve conduction study measures the speed of the nerve, so it finds the problem with nerve conduction. Whereas an EMG, or electromyography, measures electrical activity at rest and with contraction. So it assesses the activity of a muscle following a stimulated nerve. This should look familiar from our last lecture, except this time we're going to talk about it in regards to the motor system. The primary motor cortex is located in the frontal lobe along the precentral gyrus, and this is where all of our motor output initiates or starts. Again, the homunculus is larger in the areas of the face and the hands due to the need for more fine motor control and coordination. And this also should look a little bit familiar from our last lecture, but today we're going to focus on the descending spinal tracts. These are the motor signals that are moving down to the body to produce movement, reflexes, and autonomic functions. We're going to talk about each of these tracks within the next couple of slides.